Existing in the middle of the lush and prosperous Sundanese area, which is rich of various culture, and natural magnificence. Becoming milestone in educating the nation, building persons to be society servants and nation founders. Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support to establish a higher education institution with various disciplines. Launched by President Sukarno on September 11, 1957, today, UNPAD has a large number of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the vision and mission of UNPAD to be excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative research. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society. Nowadays, UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 152 study programs. Faculty of Law, Faculty of Economics and Business, Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Faculty of Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, Postgraduate School. Realizing the importance of learning process, curriculum and learning method are continuously developed in order to adjust the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge, skills, attitude and behavior with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing graduates. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Padjadjaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities such as library, Basic Science Service Center, Language Center, e-learning, teaching hospital, and dental hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Padjadjaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Padjadjaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research implementation have been conducted to give real benefits for all society. Universitas Padjadjaran, straightening and developing together with society. From West Java, for Indonesia, to the world through SDGs.
Greetings from Transcendent 2021, massive open online course in Cleft and Palate held by Faculty of Dentistry Universitas Padjadjaran in collaboration with Smile Train and Indonesian Cleft Center. Let me introduce myself. My name is Rashid Abdulaziz. I'm a dental student from Faculty of Dentistry Universitas Padjadjaran. Good days, good morning, good afternoon, and good evening to everyone here. Thank you so much to all of our participants that has been joining our courses. And thank you so much to the participants that can make it into today's live discussion. So today is our 30-second live discussion, which means we have discussed a lot of aspects about cleft and palate, from the introduction, the genetics, the embryology, the surgical treatment, a little about cleft speech therapy, the telemedicine, even the social aspect. So today we are about to discuss about the impact of cleft palate to speech with another amazing speakers. We have Miss Nana Akua Owusu from I'm sorry. We have Miss Nana from Ghana as our speakers today. Hello, Miss Nana.
Hello, Rashid.
How are you?
I'm good, thank you.
Okay. Thank you so much for being here. We really appreciate your presence here. So, Miss Nana here is from Speech and Hearing Center, Ghana, right, Miss Nana?
Yes. I also work for the university. Yes.
Oh, we really appreciate your presence here. And we also have here Dr. Anggun Rafisa as our moderator. She is one of our lecturer in oral biology department, Universitas Padjadjaran. Hello, Dr. Anggun.
Hello, Rashid.
How are you, doctor?
I'm good, thank you.
Thank you so much for joining today's live discussion. So maybe before we start today's live discussion, I would like to explain a short description about this live discussion. So this live discussion will be separated into two sessions. In the first session, the participant has filled out the question through our website, to our MOC website. So then the student committees will have provide the question letter on the screen. And then on the second session, the participant here will have the opportunities to ask the question directly to Miss Nana by opening their microphone and video. So they can ask the question and then Miss Nana can answer the question. So maybe not everyone can make it into today's live discussion, but the recorded version of this live discussion will be posted on our website. We are very thankful that we have gathered around 900 participants from around the world that successfully joining our courses. And then I hope the participants can watch this live discussion later. So I think we can start the live discussion, and I would like to give the spotlight to Dr. Anggun as our moderator and Ms. Nana as our speakers. Thank you so much.
Okay, thank you very much, Rashid. Hello, everyone. My name is Anggun Rafisa, and I am the moderator throughout this live discussion. And in this session, I will read the question submitted by the participant in MOC, and then the question will be answered by Ms. Nana. Okay, Ms. Nana, can I start reading the question?
Pardon?
Can I start
Yes.
reading the question?
Yes, you may.
Okay, committee, please. Okay, the first question from Farsha, Universitas Pajajaran. And the question is, have you ever did the speech therapy to adult patients? What's the difference? Is there any different result? And how you manage a patient that is so hard to be trained? Please, Ms. Nana.
Okay. Thank you very much. And thank you for the opportunity to be part of this discussion and this program. Yes, I have worked with adults, but fewer adults than children. The majority of my caseload or the caseload that I've had have been children, and I've worked with a few adults. Now, for me, it is just that little bit more difficult. In fact, right now, as I speak with you, I'm working, I have a 20 or 21-year-old that we are working with. And the difference is that for the children, depending on the child's age, the resources, the materials that you can use are many because it's all play-based. And so it's easier to work with the children. And a lot of the things that you do are repetitive. So for example, if you're doing things relating to speech drill, it's more like, speech drill for some of the activities that we do. And it is easier and lighter if you can do it in a play form. So for the children, it is easier to do it in play form because it's play-based and it doesn't feel like you are working too hard. Now for adults, it's more difficult. And because they would have come with a way of talking that is much more difficult to be able to work on. I have found adults a little bit more difficult. And apart from the issues with speech for an adult, they have all the other situations going on for them, so they may be working, they need time to go to work, so fixing appointments, organizing appointments, they can't turn up for this appointment because they have to do this and they have to be somewhere else. So all those things make it even more difficult to have like consistent appointments. Now, if they are little, the parents realize that, okay, if we are able to do something about this child faster or sooner, by the time they are a bit older, it will be corrected. So the parents will make a lot of effort to bring the child and on time and regularly. But when they are adults, it's more difficult, and they can, they can decide, okay, after all, I've had clients, like older clients, and they've said, well, after all, I've been talking like this nearly all my life, and it looks like it's going to take a long time to get to work on this thing, on my speech, and I really don't have that time or the patience, and it feels like, it's like some of the things I have to do is like I'm a little child, so they opt out. So I find that many of the older people opt out. Now, this young man that I am working with now, I think his surgery was really well done, and I saw him. I must have seen him many years ago. I think maybe about 15 years ago when he had the surgery, and so he was very young, maybe about 5 years or so when he first came. And I don't know what happened. They just stopped coming. I think they said I don't know, he just decided one day that, he didn't want to come anymore. So they stopped coming. And now he's coming, and he has seen a lot of difference in the way that his speech is, even in the short time that he's come. And so it is making a lot of difference. And again, if the surgery was done very well, then when they are older and they come, it is also easier, because then you can make progress much more quickly. But if the surgery needs, you need further work to the surgery that was done, then it makes it even more difficult, and so people give up. So I have found that many of the older people that I have seen, they have given up. They have given up and did not continue with the sessions throughout. So I do find working with children much easier and more rewarding, and you feel you get a lot from it with the adults. So I think with the adults, a lot of what I have been doing is also supporting them and helping them build up their confidence, and then give them, the various strategies that they can continue to apply even if they stop coming. Now, managing a patient that is so hard to be trained, I'm not sure what that means. You mean that the client, it's difficult to train the client? If it's difficult to train the client, is it because the surgery, the surgery was not well done, or because I'm not sure what that means? But I think that could depend. That could depend on the surgery, the nature of the surgery that was done, and whether it was well done or not. But otherwise, if the person is motivated enough, then usually I find that they can be trained, when you mean that they can be helped to correct the way that they're talking. Now, if it is hard to be trained, then I think it's important to talk to the client, maybe a little counseling, and then find out what other circumstances or other things that could be going on in the life of that person, which may be affecting the ability to be trained. So I think for majority of people who want to change the way they are talking, and we know that, talking is extremely important, how you are talking and how you are presenting is so important. So when a person comes to you, they really want to do something about it. And so I would say that for the majority of people, they can be trained. It's that you just need to get them, in the right frame of mind and at the right place. So if you find that somebody is being very hard to train, just give yourself a little break with the person and just make it a relaxed session, just maybe talking generally and finding out a little bit more about what may be going on in that life of that person that could be impacting on their ability to be trained. So thank you. That's what I think I have. I hope that answers your question.
Okay, thank you, Ms. Nana. I think it's a very clear answer. Thank you. We can continue to the second question. Okay, it's from Faras, Universitas Pajajaran. Based on your experience, which is more often caused by velopharyngeal insufficiency, hypernasality, hyponasality, or mixed nasality? Please, Ms. Nana.
Well, usually the first, hypernasality. That is what I would normally find. Hypernasality would be, in my experience, what is more caused by the velopharyngeal insufficiency, so that it's not the gap is not closing. So as air is going through both places, you would find more hypernasality, maybe some mixed nasality, but certainly hyper, not so much hypo, but I tend to find more hypernasality. Yeah.
Okay, thank you, Ms. Nana. Next question. Okay, it's from Hasna, Universitas Pajajaran. How do you treat uncooperative early cleft patient so as not to cause speech delays? Please, Ms. Nana.
Uncooperative early cleft patients, uncooperative as in the child or the parent, you know, because I do a lot of pediatrics and they would normally be with their parents. Now, one of the things that we, I'm no longer at that hospital now, that's the main teaching hospital, but one of the things that we did, and is still being done, is to have other older clients, so clients who have gone through the process. So new clients meet older clients, or people who have already been there and gone through the process. And so as a result of that, I think that many people tend to cooperate sooner. So for example, if you came in with your baby and you saw other parents and you were allowed to talk to other parents who also came in with their babies or their children and now have progressed to maybe a level where their child's the lip has been repaired, or maybe the palate has been repaired, or you find more than maybe one or two other parents who will talk to you about their experience. And so you see it and it's right in front of you. And we get the parents themselves to encourage you. So I think it is actually a bit difficult. I'm not sure what you mean by uncooperative early cleft patients, because most of them are children and they come with the parents. So the child can't be uncooperative, but usually the parents want to see a change in their children. And so they are normally cooperative. And because you can see other parents who have gone through the process and who are there to also support you and advise you, I think it makes it much more easier for them to be more cooperative. So I think if that's what you mean. Now, if the only other way that I might interpret uncooperative here would be maybe people who are not consistent. So once you say, for example, if you have a 3-year-old, because I have come across children who were like 2 years or more before their palate, they discovered that there was a hole in the palate, which is a bit unusual and a bit odd, but it happens. So, I mean, if you have parents, the people that I might call uncooperative, people who are maybe not consistent. So they tend to not maybe come to the appointments as regularly as you would expect them to. But then again, if we explain to them how that is going to affect the child's speech and how that is going to impact on the child's speech, I think we do get them to come. And in our case, we have people coming from quite far distances. I mean, thankfully, we because of Smile Train, we have a small grant that supports transportation costs, and so for some of our families. And so they do come once they get that transportation support. They do come. So how uncooperative that is how I'm not sure what you mean by uncooperative, but because we have that program or system that supports newly discovered clients, I think that makes a lot of difference for them, and it helps them to be able to come for the sessions, so that speech delays will not be a thing for them if they do come. So far, it's not been so bad. Yeah.
Okay, thank you, Ms. Nana.
I hope the person that is asked the question understands, or maybe they can come up later with a follow-up question if I haven't answered it well enough, because I think sometimes sure what they mean by the uncooperative.
Okay, maybe we have Hasna here today.
Hasna
Okay,
here?
is Hasna here? Or if Hasna is not here, we'll make sure that she'll watch this video, and if she has another question, we'll follow up to you again, Ms. Nana. Okay, and this is the last question for first session, and we can continue to the second session where the participant that want to ask Ms. Nana directly, you can simply use the raise hand feature or type your question in the chat box. Do we have anyone? While we're waiting, maybe I want to ask you a question, Ms. Nana. Well, in this pandemic, even though you said that in Ghana, pandemic is not really affecting people, but we in this pandemic have the government required us to always use a mask. Do this protocol affect you as a therapist and in performing a therapy to, especially to a children, Ms. Nana?
Yeah, but I just want to correct the first bits of your statement that the pandemic is affecting some people. It's just that currently I'm not seeing, I'm not seeing as much as before, but it has affected quite a lot of people here too. Yeah, yes, I think much earlier on, we raised issues about the mask and the difficulty or the challenges in using mask as a speech and language therapist, and people who have issues with their communication, and especially working with children, and sometimes children who are usually mostly non-verbals. It has been a huge challenge. But then we discovered that, on television, for example, the government allowed the interpreters for the deaf. So the government allowed the interpreters for the deaf to wear the shield, the transparent shield. So the government allowed them, I saw them wearing the shield to do the public interpretations for ministers and the government officials. So that's what we also adopted. So we use the shield in our sessions. Not that we don't, so we use a shield, the transparent one.
Yes,
that is
face shield.
Yes,
right?
yes, yes, the face shield. So that's what we use. We tend to use the face shield, and that's help. But it is a huge challenge, even with the shield. Still quite a challenge, because there are children who find it very difficult to see something in your face, and wanting to pull it off all the time. So it has been a challenge, but I think that has helped. Having the transparent shield has helped us in being able to do our work to some extent. Yes.
Okay, Ms. Nana, thank you for answering that question. Do we have a participant that want to ask directly to Ms. Nana? Rashid, is anybody raised the hand?
I think Josefinda raised her hand.
Okay,
So
okay,
Josefinda,
Josefinda. Okay, please, Josefinda, you can turn on your microphone.
Okay, thank you so much for the opportunity. Good day, Ms. Nana. Good day, Dr. Anggun, and good day, Rashid. My name is Josefinda. I am a preclinical dental student from Universitas Pajajaran, Indonesia. So I would like to ask the questions to Ms. Nana. When the Cleft patient has been treated with speech therapy, will their speech become fully functional like a normal person? Or is there any possibility their speech is not fully recovered?
Okay, so it depends on the clients, and there are some people whose speech are back to normal, as if I make, so they typically they talk normally, and then there are some that may have some residuals. Okay, so they may need because they are not able to clear it, but generally for the if the surgery is good and the surgery has been done well, then I don't think that there should be any issues or any problems, because that's the whole point of the speech therapy, is to get the person to talk normally. If all the structures are in place and everything has been sorted, then yes, that's fine. Now, what I find is that when people are not consistent with therapy, and they may come one day, they don't come the next day, they come another day, they don't come so because they are not consistent, they may clear a lot of, say maybe hypernasality, or they may clear, but sometimes the mislearning, if they have mislearned the way of talking, and they are not consistent with therapy, or do not continue with the strategies that you show them, because, well, you really also need to be conscious, especially if it is mislearning. You need to be conscious of using the right form, and making sure that the airflow is coming through your mouth rather than your nostrils. So if people are conscious and they want to do that, then yes, the majority, what my expectation is that people's speech will be back to normal. If all the structures are in place and if everything is working normally, then I expect everything to be in place. So yes, a significant number of the children or the people who come through do get their speech back to normal.
So we don't
But
have
it's a long,
so
but
we
because
don't
it's, sorry, go
just
on.
you go first.
No, because it's a process, because for many of the children, the impact can be so huge that they need therapy over a long period of time. So maybe in some situations you might think, oh, this is never ending. But if they are consistent and the support is there, then we are hoping that, for many children, maybe by a certain age, depending on when they started therapy, they would be okay, and their speech would have, mostly corrected.
Okay, so we don't have to worry about the speech ability of Cleft patient as long as they do the speech therapy well, and then if the surgery done well, right, Miss Nana?
Yes. If the surgery is done well, then the speech therapy will be very effective. Yes, the surgery is done well. And you know that right currently, I know that internationally, I don't know if that's been changed. Once the child is between 3 and 4 months, that is supposed to be the best time to do the lip surgery, because doing the lip surgery around that time kind of coincides with the time when the child is likely to be babbling. Okay, because the babbling starts around, just about 4 or 5 months onwards, and then babbling starts. So once that's the lip is repaired around that time, then it prepares the child and it helps the child to have the lip seal and the lips ready to be able to do the ba 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 ba, and all those funny things that we do. Even the pouting for the kiss, like the and all that. You use your lips, and you need both lips for that. So when the lip is corrected, or the lip is repaired, then around that time, it makes it easier, because the child can babble and begin to practice sounds in anticipation of, words and talking in future. Now, by 9 months, generally, I know that my surgeons here that I have worked with before, they tend to do the palate. They repair the palate around 9 months. And around 9 months, some children would have started to say single words, okay, and making some syllables. So by 9 months, they might be saying the bye, they might be saying the da, 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 ba, ga, ga, they may be saying most of these sounds. And so by 9 months, when that is corrected, when that is repaired, now they have the palate for the articulators to be able to move, appropriately, and to be able to make those sounds appropriately. And then they start hearing the correct form of the sounds that they need to make around that time. Okay, so between 3 months and then around 9 months, I know some people do it about 12 months or so, but the later they repair, the more likely the child is going to have phonological or speech problems for longer. Okay, so the longer, because the longer it says once the child, let's say the child does not have the repair done before 1 year or 18 months, and then they start trying to talk. So once they start trying to talk, they're going to talk in a different, they're going to compensate. So for the sounds that they cannot make, so for example, they may not be able to make the sound s, they can't make the sound d or t because it is in the region of the palate. So if they're making the s sound, they might make the h sound. Okay, so yeah, so instead of sun, they might say hun. And now if they do that over a longer period of time, now that becomes a way of talking. And so even after the repair, sometimes it takes a while for them to understand that, to work it out, okay, and to follow what we are teaching them and showing them to do, because their way of expressing or articulating has been compromised over time. So all those things, that's why I'm saying that the surgery, the timing of the surgery, and then the quality of the surgery are all important precursors, you know, for speech therapy. Yes.
Yeah.
So once, sorry, hold on a second.
Okay.
Yeah, so they are all important precursors for therapy. So if all those things are done, then it makes therapy faster and easier. Okay, so once that is done, so let's say we have a child who does their, whose lip is repaired 3 to 4 months, they don't have any feeding issues. Okay, so, and again, if they have feeding issues, then the therapy, the lip seal, the repair of the lip might take longer, because if they have feeding issues and problems, they will not gain the right weight to have the surgery done at the right time. And so it just goes on and on. So all those things need to be corrected and in place before the surgery is done. And so when the surgery is done at 3 months or 4 months, and is done by some competent surgeon, and then by 9 months, the palate is corrected, and they have speech therapy, the support, and parents are doing what we ask them to try and do. Then for many of those children, I mean, I've had children who have had palates repaired, and within 6 months, they were clear. And I didn't see them again after 6 months. So they were talking normally. They didn't have any problems. So there's a lot that needs to be also in place for speech therapy to be effective. Does that make sense? Yeah.
That
So I think
very
after
makes
about,
sense.
yes, and then sometimes from, and then the dentist, for me, the dentists tend to kick in more around 6 to 7 years when the child's milk teeth have all been erupted, or the new teeth is coming into place. And I tend to find that the dentists tend to come in a lot more then. But there's also a lot that they teach them right from the beginning that they need to do before that time. So yes, it can be effective, but certain things also need to be in place.
Okay, thank you so much for the explanation, Doctor. That's very clear. I can understand it very well. Thank you so much, Miss Nana.
Thank you too. You're welcome.
Okay, thank you, Josefinda. And Ms. Nana, regarding your explanation before for the Josefinda questions, I want to ask that, is it very possible to Cleft baby to catch language milestones like any other babies without oral birth defects, as long as the surgery conducted earlier and well? Is that correct, Ms. Nana?
Well, yes, I mean, in terms of language milestones, yes, they can, because there's nothing wrong with their intellect, okay? Their brain is working normally. I mean, having a cleft does not necessarily affect the brain. So once the brain is working, the child is able to get the language that you're speaking around them. It is the expression of that language. It is the talking, it is the speech that becomes more affected. But in terms of language, understanding language, and the ability to be able to use language, that is not a problem. But the use of language through speech would be affected. Do you get what I mean? Do you get what I'm
Yes,
saying?
I do. I do.
So understanding is absolutely no problem at all, because normally majority of these children, they do not have any issues. They don't have any issues with the brain, and they can pick up the language around them just like any other child. So the milestones will be met. So understanding milestones will be met. The ability to maybe express themselves, milestones will be met. But the abilities for speech, the milestones for speech, is what is going to be affected most likely. So because we got the speech, we got the nonverbal expression, and we got understanding. So understanding will not be a problem at all. And then the ability to express themselves non-verbally will not be a problem. But then the ability to express themselves through speech will can become a problem. Because once it's time for them to start talking, they will have problems expressing themselves. Articulation will be a problem then. Okay, so yeah, so that's what is likely to happen.
Okay, Miss Anna, I think here we have another participant that already raised her hand. It's Mutiara. Zahra, please.
Hello, Mutiara.
Miss Anna, my name is Mutiara. I am a dental student from Pajajaran University, Indonesia. Okay, I would like to ask, for cleft patient with a delayed palate repair, how will it affect the speech development of the child? And if it does affect the speech development of the child, is it possible for the child to keep up with the speech ability they should have had? Thank you, Miss.
So when you say that the late, how old will this child be, for example?
Maybe around 4.
Around 4.
Yeah.
So the child's palate is repaired around 4, do you mean?
Yes,
You mean
Miss.
the child's palate is repaired around 4 years?
Yes, Miss.
Okay, so up until 4 years, and it is only the palate, the lip is not involved, is it?
Yes, that's true.
Okay, so if it is only the palate and the lip is not involved, I just need you to think of, now, I just need you to make the sound for yourself, make the sound D in your head, D, make the sound S and Ta and Ka, and think about how your tongue is moving in your mouth as you make those sounds. Think of the position of your tongue. The tongue sometimes go back, up. The tongue sometimes stays in the middle a little bit, and it all has some connection with the palate. Okay, so it has some connection with the palate. Now imagine that there's a gap in that space, in where your tongue hits. So there's a gap in that space. So what is going to happen for that child once you are ready to talk? And remember, I just said before that your understanding of language is fine. You do not have any problem with the understanding of language. So you have a good understanding, you are hearing the sounds okay, but now that you have a hole in the roof of your mouth, you're going to try and practice making some of these sounds. So your D will sound like Your D will sound like and then your S will sound like an So all the sounds that you were supposed to make with the palate, with the support of the palate, the tongue hitting the palate, are going to be compromised. And so you are going to now try and compensate for those sounds. So you're going to find ways of making those sounds so that you are ahead. And so you are trying very hard. So when you have to say dada, or daddy, you might say And so now you may be using a glottal stop. So you may be going further down in your throat to make that sound, because you don't have the palate for it. And much of that, the air that is supposed to be coming through your mouth when you make all these oral sounds, is going to come through your nostrils. So you might be saying things like instead of daddy or dada. And so all the sounds that you have, that you are supposed to be saying around that area for the palate, for the tongue to hit the palate, Now you're going to make those sounds either further down in your throat, or it's going to be just nasalized coming through your nostrils. So instead of having a rich range of phonemes, so you have the D, you have the T, you have the S, you have the K, you are going to have maybe just one phoneme which is also compensatory, which is a phoneme which is more down the throat, like an A, like a glottal stop, or an from the nostrils. You get it?
Okay,
You
I
understand
get
what
it.
I'm saying? Yes.
I get it,
So
Miss.
that would be a challenge for you when you are now trying to communicate. And that can also affect your understanding of the phonology of the sounds, because now you are only focusing on one sound, which is the glottal stop, which is even not part of, which may not even be part of your repertoire of sounds in the language that you speak. So for example, in my language, we don't have the glottal stop really, but if you have a child with a palate a gap, then that is going to happen. They're going to have a glottal stop as part of their phonemes. And it's going to be very challenging, because once you talk, people are going to ask you to repeat yourself. If they can't hear you, it becomes very frustrating. You're talking, people don't understand. As soon as you start talking, people tend to look at you. And so it's all very uncomfortable for people too. And apart from the fact that you yourself feel bad that you are not able to express yourself well, all that is happening around you and people checking out and looking at you and asking you to repeat is very frustrating. So those are some of the challenges, and those are just some of the challenges. And again, you become also nasal, because all the air is coming through your nostrils. Now, in hand of talking like I was talking before, can you hear anything now? Okay,
Yes.
can you hear anything how I'm talking now?
Yes.
But that's okay. And then anything how I'm talking now and how I'm talking before. Do you get the difference?
Yes, Miss.
Okay, and so the
This one
person will be
is
talking.
unclear.
Yeah, so it's exactly. So it's going to be a different way of talking if you don't have it. And at 4 years, it's getting a bit late, because now you would have been very used to the way you're making some sounds. And so we really appreciate that midwives and health practitioners are taught as early as possible to be able to identify, so that they will be able to direct families to the right places as early as possible, at birth. Does that answer your question, Mutiara?
That is clear, Miss. But as soon as the palate gets repaired, can the child have this speech ability they should have had at that age? But in this case, I think for 4 years.
Yes, they can. Once the child is forced, they can. And once the child is about 4, children become more aware of themselves from that age. Okay, so they are more aware of themselves. They are more aware of how they are talking and how different that they are. And so once the child has that awareness, and you are able to encourage the child that, we're trying to help you, so that usually when I have children like that, when they come to clinic, I talk with them and I just let them know, when you're talking and people keep asking you to repeat, how does that feel? And then they'll tell you they don't like it, and sometimes it makes them withdrawn, doesn't make them want to talk. And so we talk about that, and I'll say that, what we are going to do, or what we are doing now, is going to try and help you, so that people don't keep asking you to repeat. So you try to get the child to understand, so that they team up with you and they understand what they're doing, and then it makes it easier. It just might take slightly longer then for that child, because they have been doing it in a certain time. But it does work, yes.
Okay.
It does work, because the child will have a much a wider range of sounds that they may need to correct as a result of that long wait, okay? Because by then they would have learned all the sounds that they need to know. Because from the milestones for speech sound, we have milestones for speech sounds, just as we have milestones for language development as well. So the speech sounds say from, for English speaking children, for example, from 0 to about by 12 months or so, there are certain sounds that we expect they will be able to make. Okay, so like a ba, like a ma, like a pa, there are certain sounds. By the time they are 5 years, we expect that they would have maybe mastered all the sounds in their language. So if you are 4, you have a wider range of sounds. You have nearly all the sounds in your language now to correct. And so you have a lot more work to do than someone who had this corrected maybe earlier.
Okay.
You get it? Yes.
Yes. Okay, Miss. So the child can have the normal speech ability, but maybe needs a little more time.
They will need a bit more time, and they will need a bit more support. Yes.
Thank you so much, Miss.
You're welcome. Thank you too for your question.
Okay, thank you, Mutiara, for the very good question. And Miss Nana, I think all the question has been answered, and we come to the end of this live discussion. But before we end it, do you have anything to say or mention to the participant?
I'm just wondering, the participants, the majority of these participants are they therapists already? They're students. Are they students?
Yes, some are students and also some are also dentists. Rashid, can you help me?
Yes, Miss Nana. Most of the students is coming from the medical student, dental student, social student, and also cleft therapist, also speech therapist. I mean, also being our participants.
Okay, thank you. I think, okay, so yes, so I think, yeah, no, it's lovely to have that mix. So because it's good to also understand what other people are doing and what other people do, and how what you do can complement others. So no, it's been an interesting, and it's been a good opportunity, and I'm saying thank you too for this opportunity to be part of your program of supporting and training the speech and language therapists, and also other disciplines that have joined us today. One of the things that I think I would like to leave us with is I think that when we are working with any client, a speech, and I think this came up, I've thought about this because of one of the questions that was asked earlier. I think it's important to see anybody who comes to us as a whole person. Okay? It's important to see that person as a whole person, and make sure that whatever we are doing also meets with what's going on for that client. If we have that client's full support and motivation, we are always able to do a better job than if we are in there to do our thing, and then to make the person, like, so I go in and I'm trying to make this person better, and I don't know what is going on for this other person. Sometimes it is good to be able to just allow a little bit of space to know what's going on, so that you know how you fit in and you know how you are able to support this person better. And I'm saying this, I think, because one of the questions suggested that for older people, for example, if you're working with older people, they may have so many different things. Even for younger people, for parents, parents may have so many other things going on for that parent. And you as a therapist, or you as the professional, may be just focused on that one child that they are bringing to you, but so many other things may be going on for them, and all that other things going on for them can impact on the help that you are giving to them. So for example, you give them work to do at home. So you do your therapy for 45 minutes or 50 minutes, and then you give them some homework or something that they go to continue, so that you have some continuity. and that's, you're able to generalize what you're doing a bit better. And they're going to bring it back so that you continue, and you're hoping that things will move on faster. Now, if things aren't going on as well as it should in their homes, then what you are doing is not going to work very well. So it's always important to make sure that there's a balance, so that what you are doing, you are not just doing what you're doing in isolation to what is going on for the whole person. So that's one of the advice that I will leave with you, that we see people as whole people. So they come to us, we are not just doing a little bit and then asking them to go away, but we are also taking into consideration what could be going on for the person, so we are able to give, full benefit of whatever that we do for them. So I think I just want to say thank you very much for this opportunity. This is my first time of actually having this kind of discussion, and so it's been quite interesting for me. I've had other forums, but not like this one. So thank you for the opportunity.
Okay, thank you again, Ms. Nana, for a very great and informative live discussion. So this is the end of this live discussion, and I will return it again to our MC, Rashid.
Thank you so much, Dr. Anggun. Thank you so much, Miss Nana. We are having a good time here. Thank you so much, Miss Nana, for the amazing lecture. Thank you so much for the informative explanation. I personally really grateful to have you here with us. And then thank you so much, Dr. Anggun, to be our today's live discussion moderator. And on behalf of the student committees, I would like to say thank you to all the participants for being a big part of this event. It's been a wonderful experience for all of us, and I'm personally grateful to get to see everyone who is passionate about Cleft and Palate here. I believe that the future of medicine is within us, and thank you for all of the experts who are willing to share the insightful and valuable information to all of us. Maybe before we end today's live discussion, we can take a picture first. The participants, maybe you can turn on your camera, and then the student committees help to take a picture of us. Okay, I will count from 3 to 1. Start from now. 3, 2, 1, cheese. Once again, 3, 2, 1, cheese. Thank you. Thank you so much. Thank you so much,
Thank you.
Ms. Nana.
Yeah.
Thank you so
Yeah,
much.
and you can have my address, my email address around, so to WhatsApp or email if anybody wants to, further ask any questions or link up. It's fine.
Sure. Thank you so much, Ms. Nana. We really appreciate it. Thank you so much, Dr. Anggun, and thank you so much, everyone. I hope we have another opportunities to get to meet again, and I hope you all stay healthy. Thank you so much. Goodbye, everyone.
Bye-bye.